Welcome, everyone, and thanks for those of you who are here just a couple minutes early. On behalf of Dr. Mayer and myself, we're really pleased to see you here today, and we're going to take just a few minutes to let some other folks complete the process of logging in, and we'll get underway. We'll start in just a couple minutes. All right, thank you everyone for joining this June 3rd version of the antiretrovirals for HIV prevention webinar. And on behalf of my co-host Ken Mayer, I will get things rolling. For those of you who haven't joined us for one of these sessions before, the way this will work is we're going to have 3 speakers today who I'll introduce up front. I encourage you to think about questions as the speakers are presenting. You can put those in the chat where Dr. Mayer will keep an eye on them. You can also save them and raise your hand and ask at the question and answer session at the end. So I just want to note very briefly that today's topic is, am I sharing, Ken?
No, you're not.
Maybe not. All right. So if this is a challenge to work, I will I'll just I can say it. But today's topic
now, Patrick.
Okay. Today's topic is HIV in the U.S. South, responding with science and service, which will make sense as you hear our presenters. Why are we focusing on the South? The South is about 38% of the U.S. population and over half of new HIV diagnoses. And in the national view, you really see the cities, southern cities, light up in terms of new diagnoses. But when we look at HIV prevalence and rates of people living with HIV, there's still a story of the South, but it's much more, weighs much more heavily in areas of the rural South. And so I just wanted to put up these 2 images to set the scene for, why we want to focus here. And to help us focus here, we have 3 great speakers. I'll introduce all of them first, and then they'll move from one to another. The first is Dr. Jeb Jones, who's an assistant professor in the Department of Epidemiology at the Rollins School of Public Health at Emory University. Jeb's research focuses on developing and testing technology-based implementation strategies to increase the uptake of HIV preventions among sexual and gender minority populations, with a special emphasis on rural areas in the South. He's interested in methods for measuring PrEP adherence and the alignment between PrEP use and sexual risk. Dr. Natalie Crawford is an associate professor in the Behavioral, Social, and Health Education Sciences in the Rollins School of Public Health at Emory. She serves as a co-director of the Prevention and Implementation Sciences Core in our CFAR. She's trained in social epidemiology, received her PhD and MPH in epidemiology from Columbia University's Mailman School of Public Health. Dr. Crawford completed her postdoctoral training at the University of Michigan as a Robert Wood Johnson Health and Society Scholar, and she graduated from Spelman College, where she trained in women's studies and biochemistry. Her NIMH-supported research examines the impact of structural interventions in pharmacies in reducing racial inequities in HIV, and she's currently advancing the implementation science of HIV prevention services in pharmacies in the U.S. Southeast. And last and certainly not least, we'll come into our service segment with Dr. Caroline Weinberg, who's the founder and executive director of Plan A. She's worked in the field of reproductive and sexual health for more than 20 years in roles ranging from community health worker to program manager, and in settings from New York City to rural Uganda. Her work's focus on access to care in low-resource settings led her to founding Plan A. It's an organization that focuses on bringing reproductive and sexual health care directly to communities in the rural South using a mobile clinic model. This work includes an extensive evaluation of the program, and she's the primary investigator of a multi-site study examining the impact of mobile reproductive health clinics across different communities in the United States. So you can see why I'm excited for our speakers today. I'll turn things over to Dr. Jones. And at the end of this, please remember to enter questions as you have them, and Dr. Mayer will moderate questions at the end.
Thanks for that introduction, Patrick. Are you able to see my slides?
Yes.
Great. Awesome. Thank you. So I'm excited to share a bit today about the epidemiology of HIV in the rural U.S. South and some strategies we have underway to investigating ways to increase uptake of HIV prevention services. So as Patrick just mentioned, the U.S. South is disproportionately affected by the HIV epidemic, accounting for a little over a third of the population in the U.S., but more than half of new diagnoses. And this disparate impact happens across levels of urbanicity. So these are some CDC data. These are back from 2017, but the columns here are broken down by metropolitan statistical area size. So the MSAs of greater than or equal to 500,000, you can sort of think of as urban. MSAs of 50 to 500,000 people, you can think of as sort of like suburban, smaller metro, and then the non-metropolitan grouping there are essentially rural folks. So what I'm highlighting here is that the rate of adults and adolescents living with diagnosed infection in the rural South is actually higher than in those suburban and smaller metro areas in the other regions of the U.S. So this disparate impact in the South really occurs across levels of rurality. Again, this will look kind of familiar from those maps that Patrick showed during his introduction, but you can really see that the disparate impact in these maps of HIV prevalence across the South. And this has been identified by in the HIV Epidemic Initiative that has identified 6 of 7 priority states in the U.S. South. The 7th, and those are the states that are bolded here. The 7th state, Missouri, is actually geographically contiguous, that's technically in the Midwest. What I want to highlight here is that the designation of a priority state based on a rural epidemic shouldn't be taken to imply that there is not a meaningful rural epidemic in other states throughout the South. In order to be identified as a priority state, a state needs to have at least 75 diagnoses, at least 10% of those occur in rural areas, and there's not already a priority county identified in that state. So for example, if you look in Georgia, in sort of these southern Georgia counties and northern Florida counties, that are very rural areas that are in the upper deciles of HIV prevalence. So there's the effect or the disparate impact on rural areas throughout the South is broader than just these priority states that have been identified. In terms of the sort of the makeup of the HIV epidemic and throughout rural areas and nationwide, what we can see is that the HIV epidemic in rural areas actually mirrors that in more urban areas. So for a while, we didn't really have good data on how the epidemic broke down sort of by urbanicity, but these data from CDC in 2018 demonstrate that regardless of urbanicity, again, here we've got going across the graph, columns representing sort of urban areas, suburban and smaller metro, and then rural men who have diagnosed with HIV. And the vast majority of new infections are all attributable to male-to-male sexual contact, regardless of urbanicity. So this graph is among men, so 70% of new diagnoses in rural areas are among men. 77% of those are attributable to male-to-male sexual contact. So about 60% of all new diagnoses in rural areas are attributable to male-to-male sexual contact. So what this indicates is that regardless of urbanicity, there are HIV prevention needs among MSM. And so we had a question sort of how well are these being met? And so to sort of try to assess this, we use data from the American Men's Internet Survey, which is conducted here at Emory University, and it surveys thousands of MSM each year, to sort of just look at the PrEP continuum broken down by urbanicity. So the blue bars here, urban men, orange are suburban, and gray are rural. And what you can see is that in terms of these early stages of the continuum of being aware of PrEP and being willing to use PrEP, there's no real differences based on urbanicity. There's very high willingness, and they're pretty consistent across levels of urbanicity and being in terms of awareness of PrEP and being willing to use it. But when we start to move down the continuum into those steps that require action and healthcare access, we start to see really meaningful disparities emerge. So there's pretty stark disparities comparing rural and urban MSM, but there's pretty stark disparities there that are also evident in terms of discussions with healthcare providers about PrEP and ever using PrEP for suburban men too. So these are just sort of descriptive data, but we wanted to also explore sort of maybe what are the factors that could be accounting for some of these disparities. So from that sample, we looked only among the men who were PrEP eligible based on the previous CDC criteria, and calculated unadjusted and adjusted prevalence ratios, comparing suburban MSM to urban MSM and rural MSM to urban MSM. So the middle column here that's highlighted are those unadjusted prevalence ratios for ever using PrEP. And then the rightmost column are the adjusted prevalence ratios, adjusted for education, household income, race, ethnicity, and insurance status. And recall all the participants that were included in this analysis were already PrEP eligible. And what you can see is really minimal confounding by these sociodemographic, socioeconomic factors, which to me really implies that these sort of rural specific barriers that we weren't able to account for that are likely accounting for a lot of the disparity in PrEP use. Seeing the disparities that were evident not only for rural men, but also for suburban men sort of begged the question for me a little bit about what constitutes a rural area. There's multiple definitions of rurality that are in use, but they mostly are generated for administrative purposes and then are adopted by health researchers to categorize people. From my perspective, these should really be functional definitions that are based on deficits in access to care, which is what we're really often thinking about in terms of how rurality affects healthcare use, and in this case, HIV prevention services use. So again, using data from American Men's Internet Survey, we looked at 3 different measures of categorizing rurality to see how that affected measured health disparities. So the National Center for Health Statistics Urban Rural Classification Scheme is frequently used. It's based on sort of OMB categories. USDA rural urban commuting area codes are very similar to the NCHS. They also incorporate different things like commuting patterns to identify bedroom communities and commercial centers. And then finally, the Index of Relative Rurality is a measure that was created by researchers to sort of separate from those sort of administrative uses of the other codes. That is a continuous measure of rurality that takes into account like population size and density, remoteness and built-up area to assign a score to an area, where 0 is the most urban, 1 is the most rural. And the suggested cut point is that a score of 0.4 or higher indicates a rural area. So we wanted to see how do these different measures of rurality affect the measured disparities. So the first thing I want to note here is that across these 3 different methods for identifying what is a rural area, there were some pretty stark differences in how many participants were classified as rural. Unsurprisingly, because they're relatively similar, the NCHS method and the rural urban community area method had classified similar proportions of participants as rural, 1,259 for NCHS, 1,423 for the rural urban community area codes. The Index of Relative Rurality, when we used that as suggested to identify who was rural, it was much more inclusive, and over 3,600 participants were then classified as living in rural areas using that measure. So then the question is, how do those different categorizations compare in terms of the disparities we observed? So first, we wanted to look at PrEP eligibility, just to sort of as a proxy for HIV prevention needs. And what we saw is regardless of the categorization used and level of virality, that about 71 or 72% of these respondents were considered to be PrEP eligible. When we then look at HIV prevention services use, we used ever having had an HIV test here, that the disparities comparing rural and non-rural participants were really consistent. So even in that index of relative virality measure, that's much more inclusive of participants in terms of categorizing them as rural, we saw really similar disparities, about 65 to 68% of rural participants had ever had an HIV test compared to closer to 80% of non-rural respondents. Similarly, in terms of STI testing in the past 12 months, about 21 or 22%, regardless of the categorization we used, of the rural participants had had an STI test compared to about 30% of the non-rural. So what this suggests to me is that when we're thinking about geography and its impacts on HIV prevention services use among MSM, that we need to think broadly and be inclusive. So what's sort of happening in terms of HIV prevention among rural MSM? You know, for good reason, a lot of HIV prevention research is conducted among urban and peri-urban populations, not so much among rural MSM, but rural MSM and sexual and gender minority populations more broadly experience additional barriers to HIV prevention compared to their urban counterparts. They have a greater lack of culturally competent care, sort of enhanced experiences of and anticipated stigma in healthcare and other settings, and also are often living in insular communities where they have greater concerns about their sexual identity disclosure, for example, if they're accessing sexual healthcare services. From a research perspective, rural MSM are also, by definition, geographically dispersed. They can be much more difficult to reach. So there are possible solutions here, though. The internet, mobile technologies, mHealth offer opportunities for improving HIV prevention services uptake and address a number of these barriers. There's possibilities for anonymity, to offer home-based testing and telehealth, and also, mHealth can really remove a lot of the geographical barriers that rural folks experience. So, are rural MSM actually interested in mHealth and similar strategies? Using an R56 funded award from National Institute for Nursing Research, we were able to survey a sample of rural MSM and a non-rural comparison group to assess willingness among rural MSM to do things like download an HIV and STI prevention app, order different HIV prevention products like condoms, lube, at-home HIV test kits, and at-home STI test kits, and to use location-based services in HIV prevention within an HIV prevention app to find providers. What we saw was really high willingness for all of these different features, and no differences comparing rural and non-rural MSM. Among this sample, we also did want to assess sort of like infrastructure issues. What we observed among this group of participants, who were admittedly obtained online, was that they reported very few issues in terms of being able to download apps, loading images or web pages, or using cellular data. And the vast majority also reported having high-speed internet available at their homes. So it suggests that this type of intervention could be feasible for rural MSM. A subset of our survey participants also completed some online focus group discussions to discuss their experiences with accessing sexual health care and opinions of a potential HIV prevention app. There are sort of overwhelming experiences of reporting a lot of difficulty accessing healthcare. This first participant reporting traveling an hour to the nearest big city to find a culturally competent care, essentially, in some place where they felt accepted. Another participant reported similar challenges with being particularly anxiety-provoking when they were younger and knew they needed to access sexual health care, but had no way of actually traveling on their own to a provider that they felt comfortable seeing. In terms of an app, participants reported had really positive opinions about potentially using an HIV prevention app. highlighting the potential for convenience and discretion, and also just having a place to access all the different services and information in one place. And then with particular with respect to PrEP, another participant reported that a lot of folks just don't know where to get PrEP and where to get information about PrEP. So having that in one place would be really helpful. So I'm going to close here with just a brief description of some work underway. This is a preview of some results to come. So first, I'll briefly describe the HealthMinder platform. HealthMinder is an HIV prevention app developed here at Emory University. It's for gay and bisexual MSM. We've adapted HealthMinder for multiple populations, including Latino Hispanic MSM, adolescent MSM, and transgender folks. The HealthMinder app itself I think of it as sort of a one-stop shop for HIV prevention information and services. So it's got a lot of frequently asked questions that users can browse, service locators to find PrEP providers, HIV testing providers, the ability for participants to order condoms, lube, and self-test kits, and also self-assessment. So participants can sort of regularly check in on their PrEP eligibility, mental health, substance use challenges. So the study I'll describe today is the COMBINE study. This is an NIMH-funded R01 to test a version of HealthMinder called COMBINE that's been adapted for rural MSM. And also, we're going to be looking at some strategies around implementation of this type of app. So our specific aims are to determine the effectiveness of a mobile app to increase HIV and STI testing and PrEP use among rural cis-MSM. So the HealthMinder platform has been demonstrated to be able effectiveness to do this among urban populations. The question is, how well will it work among rural MSM? And then we're also looking at these implementation factors. We've always previously included the ability to order self-test kits within HealthMinder. So we're going to assess sort of, is that necessary, or are testing locators sufficient? And then we've also added on a motivational interview intervention. This occurs within the first couple of months of follow-up. So participants participate in a motivational interview to help them develop a plan to use the COMBINE app long-term as part of their sexual health care. So our study design is, again, our study population of cis-MSM, who are age 18 to 34, who live in the U.S. South, as determined by the census, plus the state of Missouri, since it's also a priority state as well, and rurality defined by that index of relative rurality that I described earlier. We are currently recruiting participants online with community partners. Our follow-up is going to be 2 years, so we can actually see multiple opportunities for participants to test over that time, and they'll complete 6 monthly surveys to report HIV testing, STI testing, and PrEP initiation. All participants are going to have the COMBINE app, and then again, on top of that, we're going to test these additional strategies with respect to implementation. So we'll be using a factorial design, a 2x2 factorial design, to test those different strategies. So arm 1 here is just a modified standard of care. That's participants who get the COMBINE app with only testing locators included. Arm 2 participants get the app plus the motivational interview. The arm 3 participants get the COMBINE app and they can order self-test kits. And then the arm 4 participants have the COMBINE app and they get both the interview and the ability to order HIV self-test kits. So we can sort of look at the individual effects of the interview and the test kits, and then their potential interaction. So I'll just close here with the status. Again, this is work that's ongoing. So results, as you can see with the 2-year follow-up, are a little bit out into the future. This study was funded in August. We just started recruiting on March 25th with the goal of recruiting 464 participants. And I will end with a shameless plug that it is immensely challenging to recruit rural MSM. So anybody on the call with experience and any ideas, I would love to hear from you. And I would just a brief, quick thank you to all my co-investigators and funders, and I will stop there and hand it over to Natalie.
Thank you, Jeb. That was an amazing presentation. I am going to just keep it moving in the interest of time. I want to thank you all for joining and thank both Dr. Sullivan and Dr. Mayer for the invitation to be here. Also, before I start, want to note that I am trained as a social epidemiologist. I am not a pharmacist, although I'm going to be talking to you a lot about pharmacies today. Also, as a part of my positionality, although I'm a Black woman, I'm also an academic at heart. And so the lens that I'm bringing today to you is from that lens, but I'm hopeful that I am doing the best to honor both the pharmacy community and the communities affected by HIV and at risk for HIV in the talk that I'm giving you today. So I want to start anchoring my discussion today by this figure, which I'm sure you all have seen a number of times now. And to really note the stark inequities in PrEP access by race. I want to note two other things about this figure. The first is the amazing success story that we see in the increase of folks who need PrEP prescriptions and have them specifically among the white population. Over the past few years, we have had over a 30% increase in white populations, and that is an incredible success. The other point that I want to make here is we are not doing enough to reach Black and Latino populations. Over the past few years, for Black populations, we've only increased 5%. And so this is telling us something about where we are moving or where we should be moving, in that what we are currently doing is not working for the folks who need it the most. And the folks who are disproportionately affected by this epidemic. So some of the things that I've seen from my work is that there just aren't enough PrEP clinics to reach racially minoritized populations. Since we're focusing on the South and since Georgia is where my heart is, as a Georgia girl, I'm going to show you a map that comes from my lab that is specifically related to Georgia. So this is a map of our state with HIV incidents across the state, and this is data taken from AIDSview. Layered onto this is data taken from PrEP Locator on all of the PrEP prescribing locations across our state. And I want you all to think through where we have these really big deserts of PrEP access. Even in the city of Atlanta, I'll show you a more granular map of the city of Atlanta in a couple of slides, but where we see, a lot of HIVs, particularly here down in the Southwest and Southeast areas of Atlanta. There just aren't enough PrEP clinics to meet people. And then when we get into the rural areas, to Dr. Jones's point, there is a desert. But what we could have is PrEP access that looks like this if we were able to integrate pharmacies. Each of these blue dots represent 5 pharmacy locations. And so the only reason you're even seeing the map like this is because there are so many pharmacies that there would be a sea of pharmacies, a sea of blue dots, that you wouldn't be able to see anything else on the map. And so where we don't have access, we could drastically increase access, and we could fill in the inequities, particularly in the Southeast and Southwest Atlanta areas, where we see that there just isn't enough access to reach populations. And these neighborhoods are specifically racially minoritized populations. In Atlanta alone, if we integrated pharmacies as PrEP providers, we could increase access by about 20-fold. If we were to do this across the entire Southeast, we could increase access by 80-fold. So there has been a growing amount of evidence that pharmacies can operate across the HIV prevention and care continuums. This is older data from my lab at this point that is a systematic review of the pharmacy-based studies across the HIV prevention and care continuums. And today I'm just going to focus on the prevention areas. We've seen seminal work from Paul Weidel, who's at CDC, on HIV testing, that HIV testing can be provided in pharmacies cost effectively. We've seen seminal work from Dr. Lewis and colleagues in New York, showing that pharmacies can provide harm reduction services, particularly in states where pharmacists can sell syringes without a prescription. New York State has also been on the forefront of allowing pharmacists to prescribe PEP, post-exposure prophylaxis when someone has had an exposure to HIV. And there's been growing work around PrEP specifically, with similar work coming out of Seattle with One Step PrEP, and showing that we can really increase access to PrEP via pharmacies, but also adherence to PrEP over time. A couple of things I want to also note about this is that for the longest, we have really thought of sexually minoritized men, Black sexually minoritized men, trans populations, and now we are really focusing a lot on Black women. Very few of these studies are, however, directed towards these populations, and that is something that is really important. We are building the evidence to show how pharmacies can do this specific to racially minoritized and sexually minoritized populations in Georgia. We are thinking through this across a number of levels, and all of our work is really multi-level, focusing on both the policy, the community level, the pharmacy level, and the individual level. And I should also say we're integrating some implementation science frameworks to do this. And so these are just some of the studies that I'm just going to try to briefly explain and stay on time over the next several slides. So this is not moving. Okay, there we go. So in our preliminary, when we began to set this out and try to understand, well, could we increase access to PrEP via pharmacies in the South? We wanted to start with some formative data, and so we started with a qualitative study, a small qualitative study among both pharmacists and men who have sex with men. For both groups, the key themes were that there is strong support for in-pharmacy PrEP screening and delivery. Not surprisingly, privacy and confidentiality are critically important. And for the pharmacists, they kept saying, we want to make sure we have a way to train our staff. I want to also give a plug that the American Pharmacists Association has very recently created a PrEP training that is available via their website. And so there is a place for pharmacists to be able to go to get this now. We also wanted to understand, since pharmacy technicians are generally your first point of contact in going to the pharmacy, we wanted to understand what their support looked like, particularly as it relates to pharmacists. And so we found that technicians have very strong support as well. They were similarly concerned about training. And where the pharmacists felt like that they had strong infrastructure, what they meant by that was that, sure, there's a place for us to set up testing, and there's a place for us to set up counseling. We can, and as you guys have probably seen after the COVID pandemic, that pharmacists will pretty much pop up a curtain anywhere and create a small space for privacy. And so that's what pharmacists meant by infrastructure. Pharmacy technicians, on the other hand, really felt like infrastructure was how do they link the patient client to care after they test positive? Or how do they make sure that they are linked to prevention measures if they test negative? And so pharmacy technicians were really thinking about the wraparound services for clients after they came in to the pharmacy for PrEP. But both groups showed a very high willingness if these services could be performed in their spaces. So the next thing that we wanted to do was, we'll figure out, can we reach people who are at high risk for HIV in pharmacies? And so we were actually slated during this time, this was during, in 2020, 2021, we were slated to start an intervention to test this in a different way. But because pharmacies were on a skeleton crew and we actually couldn't start our intervention, we figured, well, let's see who we would get if we were able to start our intervention. And so over a 2-month period, well, we actually trained 2 pharmacies on basically a very scaled down, modified protocol, which essentially just included them putting this flyer that you see on your screen into the prescription packages for their clients, and they also had these as posters set up around the pharmacy. And in this small orange box that you see here, there was a QR code where they could scan the survey. In a 2-month period, 2 of these pharmacies screened 460 people, and based on those data, 81 of those folks would have been eligible for PrEP, which we thought, well, that's almost 18%. That's pretty good. A couple of things surprised us about this data. Well, the first thing was that we thought that we would mostly get folks who were eligible for PrEP because of sexual risk behaviors. But there were a number of people who also injected drugs in the sample. We were very happy to see that folks were very willing to engage in pharmacy services, particularly around HIV. There was upwards of 90% willingness to obtain HIV services, and a lot of people had heard of PrEP as well. When we asked about their comfort receiving HIV services in the sample, and for PrEP specifically, the number one barrier to PrEP was that they didn't know enough about PrEP. But most folks had really positive attributes to PrEP. They thought PrEP was likely to work. But a lot of them also thought that PrEP was probably too expensive for the general population. This work will be coming out soon. It's conditionally accepted from the Journal of American Pharmacists Association. So once we were able to get everything up and running for the intervention, we essentially created this model that we thought would work, considering the legislative barriers of our beautiful peach state, and some of the things that actually can't be done in pharmacy. So each state has a board of pharmacy that decides the scope of practice for that state, and there were some limitations that couldn't happen in the pharmacy given those in Georgia, and that varies across the Southeast. And so we're exploring that more now, which I'll talk about a little bit more later. But for this model, specifically for the PrEP Up Pharmacies model, we wanted to create a model that was both pharmacist and pharmacy technician led, so that we could sort of see to the best of our ability how this might work without research. We needed to create a self-HIV testing model because currently, pharmacists aren't able to do that, and particularly in resource-poor environments where a lot of our epidemic is in Atlanta. Pharmacists often can't afford a nurse practitioner or a full-time employee to be able to do that or devote that time. And then this model also had teleprep linkage. So if someone tests negative, there is someone on call, our medical director, who can provide an over-the-phone prescription for the individual to take home in the same day. If the person tests positive, then we do immediate linkage to care. And we do that via a Uber ride to one of our community partners who provides treatment services. And then we wanted to assess whether or not people took their PrEP over the next sort of 30 days. So I am going to give you sort of the overview. I'm not going to dig too deep into this, but you're welcome to reach out to me if you want the specific numbers. We're working on this manuscript now. You can also, I'm also going to dig more into this in some future presentations, which I'm happy to share with you guys about. But overall, I think what the big take home here is, this was a small study, but 12.5% of the folks who came in would have been referred to either PrEP or treatment. Now, this is positive news if you are a pharmacist or a pharmacy owner, because you want to make sure that this is a business model that you can integrate into your pharmacy so that it's actually revenue generating. The other good thing about this for us is that we are seeing that the pharmacy just can passively reach a number of people who are at high risk for HIV. And that is where I am thinking, and where I think there's a lot of area of growth that we need to reach equity, to increase equity. A couple of other points about this is that this is a 100% Black population. This pharmacy that we perform this in is one of the has one of the largest Black populations in the city of Atlanta. And another point, because I think this is also really important as we're thinking about where the epidemic is going and next steps, is that we had a number of people who were eligible for PrEP. And this was we tried to promote a disease neutral and stigma free model where anyone who was at risk would have been referred. And a number of those folks were women, and a number of those women said that they weren't interested in PrEP because they did not think PrEP was for them. And that is because some of the messaging that we're seeing. And so that is something that I think we have to think about as a scientific community, is that there is a population of folks who may be unwilling to think about PrEP as a prevention option because they haven't received messages that PrEP is for them. On the pharmacy side, our results were really promising, but with some caveats. So we did an extensive training on Canvas. I have 2 slides, Patrick. I see you're coming for me. We did an extensive training on Canvas, so we provided continuing education credits for. Our pharmacists and technicians thought this was acceptable. However, it was not easy to get them to do this. Integrating this into their workflow required a lot of effort and time. That is because it is very difficult to get pharmacists off of their line. And so we have to think about how long these trainings are, which this one was short, but I think the one from American Pharmacists Association is probably a bit too long for how we could expand this and scale this, particularly in these types of neighborhoods. On the implementation side, the pharmacists and techs also thought this was very acceptable. Their implementation of this varied depending on their client flow. If it was busy, they weren't telling anyone about the study, which made sense. But importantly, this was under a research house. And so this is likely unsustainable without a consistent payment model. And so without us paying for everything, this would not be performed, even with this pharmacist who was very public health minded and wanted to do what they could to reduce HIV. So our next steps are that we are continuing in this path. We're taking a couple of steps back. In order to really get PrEP integrated, we have to get HIV testing integrated into pharmacies first. So we are advancing the implementation science evidence of integrating HIV testing into pharmacies through the PATH study. And then what we think of as like an additional puzzle piece to that, to getting us to PrEP, is to figure out, well, if there's HIV testing in pharmacies and people can test there and we can get people counseled, well, could we get clinicians to work with pharmacists to provide these teleprescriptions using collaborative practice agreements? And so we are going to examine the implementation science of establishing collaborative practice agreements between pharmacists and clinicians, which will essentially give them the legal flexibility to be able to provide PrEP seamlessly. And so just to close, we really need to focus our efforts on inequity in HIV resources, and pharmacy-based interventions, I believe, could specifically do this for racially minoritized populations. And we need to supplement these interventions with policies that promote sustained integration. So we need to focus on making sure we can train the pharmacy workforce. And we really need to focus on payment pathways. And that is both on the local or state level and the national level. I want to thank my pharmacy staff and clients who participate in our study. I'm the luckiest PI in the world. I have an amazing team of folks that I work with and my funders. And if you need to reach me or would like to, you can reach me via email or social. Thank you so much for your time.
Thank you, Dr. Crawford. Dr. Weinberg, you're on. I'm just going to say, so you can run right up, I'm going to put in the chat, but if you want to post questions for any of the speakers, I will get them back to the speakers and we'll get them back out to you so that Dr. Weinberg has a full time for presentation. So post questions in the chat for any of them and I'll circulate them. Dr. Weinberg, over to you.
Hi, I'm really glad to be following on the heels of those presentations because it's really, oh, let me see, I think I just turned green. Anyway, it's really incredible to kind of see all of the numbers out like that as we as I kind of transition into the work that we're doing directly on the ground with Plan A, which is, so we're an organization that focuses on bringing healthcare directly into communities, primarily using a mobile clinic model. We're in the Mississippi Delta, and which is the poorest region of the poorest state in the country, and about to open in Southwest Georgia. And we have these beautiful mobile clinics that drive from town to town with a focus on towns that are less than 100 people. And these statistics are focused on people in need of contraception, but it focuses on like Title X clinics and departments of health. So the numbers statistically with access to things like HIV care are similar, which is essentially that there's an extraordinary lack of access. 75% of women in need of subsidized family planning services are facing those barriers, and the numbers are similar around access to HIV and STD testing. In our counties, 40% of people are underinsured and uninsured. 37% live at or below the poverty level. The Delta, Mississippi as a whole is 13th in the nation for HIV prevalence and has the highest rate of STDs in the United States. I know sometimes when you're talking about like the Mississippi, Alabama, Louisiana, Georgia, it's kind of a race to the bottom on things like that. But the numbers are just horrible, and the entire area is a healthcare desert. And just for a little bit of context, also I should mention well, as soon as I open my mouth, it's obvious that I'm not from the South. And we work with an entirely local team of people who are delivering the care on the ground. And so you're hearing from me because they are currently out in the community delivering services. So I recognize that I'm about to tell you some stories about people who are from a community that I'm very proud to serve, but I'm not a member of. So I just want to kind of acknowledge in that context. So we operate mobile clinics which address major barriers to care. So one of them is distance. Again, a lot of these statistics are around repro, but is distance. It is enormously difficult to get to providers in rural America, particularly in places like the Delta, which has the lowest provider to patient ratio in the country. It is the distance that you have to travel is incredible. The time to travel to take off work, the cost to travel increasing, obviously with the cost of the visit itself. And even if, and then there's a major trust issue where it's not just the trust in the healthcare system, which given the history of reproductive injustice in these communities is substantial when you're talking about reproductive and sexual health, but it's also, and this was mentioned before, confidentiality is a huge cause for concern. In the Delta, even if you have a doctor in your town, often you won't feel comfortable going to them because you recognize that, or you're concerned that they might run into your parents at church, or you're going to see them in Walmart, and there's going to be a lack of confidentiality there that really presents a significant barrier to care. And then people decide to travel to the next closest place if they can. And it's just another way that you can't access care. So the mobile clinics have an enormous advantage in the fact that we come to town and deliver services and then leave. And they're not gonna, we're not a constant presence. We're not the people who they run into in Walmart or the Dollar Tree. And that adds a real layer of confidentiality, in addition to the fact that when I originally started this program, back in 2018, the focus was exclusively on reproductive and sexual health. It was going to be birth control and STD testing and HIV testing, and that's where we lived. But then the feedback we got from the community was that focusing on those topics would decrease the amount of the work that we could do, because people wouldn't want to come into the clinic because it would be known as the sex bus, and there wouldn't be any confidentiality because everybody knows your business the second you set foot on board. And so we ended up expanding and incorporating our HIV-related services and STD really in relation to like just a standard part of primary care. Like you come in for a blood pressure check or a blood sugar check, we're going to offer you an HIV test, give you the whole speech about why. And I think something like 70% of our patients, regardless of why they come in, are now getting HIV tests, which is enormous. And has had a really big impact on the community. We've identified like many people with HIV who 75% of them say that they wouldn't have gotten the test or the treatment if we hadn't come to town, because we're going directly into areas like homeless shelters, like housing projects, partnering with food banks, where people who we know are facing these barriers to care, where we can bring it directly to them. And we have this big, beautiful clinic. We use New a lot in 40 square feet, it turns out. But one of the things that we also learned was that there's a lot of studies showing that some people actually prefer getting care from a mobile clinic because it's a more kind of casual setting, I guess, is the way that they view it. But what we discovered was that you don't actually need this like fancy $300,000 mobile clinic in order to be doing these services in the community. We have found that, for example, at like community colleges and universities, we will do more testing setting up in like a glorified janitor's closet than we will if we actually have the mobile clinic on campus. If you're inside the student union doing testing, that's going to have a huge impact. And then the testing leads to the provision of things like PrEP and PEP, because you have those conversations and there's a real lack of education around what PrEP is and how to access it and what it means and who should be on it. And so once we are entering those conversations, we can expand the knowledge around it as much as we can. So the services that we offer are, all of our services, as I said, are delivered by people from the community itself. And our community health workers are a big part of how we deliver that care. They're community members who are trained in healthcare and in testing, and it has a significant impact on the work that you can do when the outreach and the education and the care is coming from community members themselves with a shared experience. Our community health workers do patient education, diabetes and hypertension screening, HIV testing and counseling, PrEP counseling, contraception counseling, and connecting people to services. And then where our nurse practitioner comes in is, the provision of PrEP, HIV care, kind of everything in the next step. And I think the easiest way to kind of explain the impact of what we're doing is probably just to tell like one or two anecdotes, because what we're really seeing on the ground is unbelievable in the lack of access to care. And we have done stuff around telehealth, and we've found that to be very effective, but there's a lot of resistance to it sometimes in the community. We had a significant uptake actually in telehealth when we stopped asking people to do video calls or requiring an app in any way, because that was a real barrier for our communities. And so now we just like straight up do a phone call with people, which had a huge impact. But with some of these things, you still need to see someone in person. So one of our earliest conversations around PrEP was a Black woman who came in asking for, whose partner was HIV positive, and she came in asking for PrEP. And when we said we could help her, she was so relieved. And it turned out that it was because she had gone to her primary care provider, done everything right. She said, she said, I know that I'm high risk. I know that that I'm being exposed. I really want to go on PrEP. And the provider who she was seeing said, oh, that's only for gay men, which we all know is absolutely not true, but she left without what she needed. And so we were able to go in and then provide that care, but it really shows the lack of education, not just with patients, but with providers on who is eligible for this and who can benefit from it. And then the other story, and then I'll stop, is just so you can understand like the significance of what these numbers are on the ground, is we had a patient who came in, and he came to us with 8 hours left of his 72-hour window to get PEP. He had been exposed to HIV. He didn't know what PEP was for the first 2 days, and then someone told him that it existed, and so he was put in touch with us. And we were able to get him do a telehealth appointment and get him the prescription written. But we called 15 pharmacies in the Delta, and not a single one of them had PEP in stock. None of them. We ultimately found the last one we called had 2 pills in stock, which we got and gave to him. And he started in time, and we ordered him a week of those meds. We ultimately started offering them in our own pharmacy because obviously this was kind of an unacceptable discovery. And he didn't have insurance, so it was $1,200 for a week's worth of medication to prevent HIV. And he had made all the calls, he had tried to get all the access, he had tried everything he could, and he just could not get it. And then we told him about PrEP, and he transitioned from PEP to PrEP. He was HIV negative at the end of the treatment, and we were able to keep him on that. And he has since been sending other people to us. And another way that we work within the community is that with something like PrEP or with HIV care, you do need labs, right? And so we'll partner with other people offering telehealth PEP or PrEP or HIV care, and we'll say, listen, when we go to town with our mobile clinic, we'll draw the labs for you, send you the results, and that way the patient doesn't have to come in. They can just see you via telehealth. And if we're doing telehealth with a patient in another area, we'll contact a local clinic and say, you know, the patient's going to come in and get the labs. We'll pay for them. If you send them results, we'll continue that care. And that broad network of providers with finding ways for people to get labs, finding ways to plug in treatment in these rural communities where trust is such an issue, you can't always be the one who's delivering care. You have to be willing to send people to someone else who they already trust. That's an incredibly important part of delivering care in rural communities, of making sure that people have access to the care from who they want to have access. And the best care that you can get them is the closest place that they can get to. It's not always going to be you, which is a really important lesson to learn, because I know the instinct is always to keep patients in-house. But one of the ways that we've built trust in the community is recognizing the fact that we're not always the right place for everyone, and bringing care directly to people in partnership with local community organizations and with other providers to make sure that that HIV testing, PrEP, and treatment is a standard part of care. And I'll leave it at that.
Carolyn, thank you so much. That was excellent. And thank you, Jeb and Natalie. We're running towards the end of the hour, but really wonderful discussion. And Carolyn, if you could put your email address also in the chat so that people can contact you. Just want to remind folks that we're going to have Dr. Rupa Patel August 5th talking about the rollout of long-acting injectable cabotegravir. These are really inspiring talks. We have a couple minutes, so maybe a quick lightning round of questions for Jeb. A question about were trans people included in the app study. For Natalie, what additional steps can be done to build capacity across pharmacies, for example, working with some of the big pharmacy chains? And for Carolyn, what do you think can be done to replicate the wonderful model that you've created? Because clearly there's an unmet need. So each of you can please respond to those questions. Roll out the hour.
Sure, I can respond briefly about the inclusion of trans folks in the app-based research. We were fortunate to receive a supplement award to adapt HealthMinder for transmasculine folks as part of a previous R01. So that included an adaptation of HealthMinder and a pilot study that was in which we found that the adapted app was acceptable and feasible. There are sort of different concerns among different populations in terms of the questions they have and different characteristics of HIV prevention. And so we've really focused on having apps that are sort of specific to populations. So the current study I described combined is for cis-MSM exclusively. I will say that another thing that we're working on is a web app adaptation of HealthMinder that's going to be a lot more flexible and allow a lot more adaptations to be much more cost effective and feasible. So it's going to really give us the opportunity to serve a lot more populations in a cost effective way. Thanks for that question.
Thank you.
To respond to my question, there are a number of chain pharmacies who are already engaged in this work and working on the ground, like in the pharmacy, to build capacity to increase HIV prevention services, but also to build capacity across the policy level within their states to shift the scope of work around what pharmacists can do for HIV prevention. All of my studies, we also include someone like a pharmacy chain advisor. And so we're working with them, although I mostly exclusively focus on independently owned pharmacies. But there is a lot of work to build capacity across, and I've been in a number of meetings in the past year with all of the big chains, and they are all very much aligned in wanting to push this work forward.
Fantastic, thank you. And Carolyn.
I'm sorry, I have no idea what's happening to my camera, but the thing is opening, launching a full-blown mobile clinic program, which we help people do all the time, and I'm happy to talk to anyone about, is like labor and cost intensive. No lying about, no mincing words about that. But it's very easy to put together what we call like pop-up clinics, which is just going into the community with someone with a community health worker who's just a trained community member who can do an HIV test, with a phlebotomist who can draw blood, or with a nurse practitioner. It can be kind of any range of people to go in and deliver services. The barrier to entry for that is super low. All you need is like a CLIA waiver and a place that will let you set up shop. And that's really the best way to build trust in these communities, is going directly into them, partnering with organizations that they already trust and that already deliver care, and just straight up showing up. So that's how to replicate it, is to just do this, like the very basic easy money work, like low money work, and then you can build your way up. But pop-up clinics are really, to me, like the best way to get started with this. And if anybody is interested in help on that, I'm certainly willing to offer any kind of guidance and knowledge I have, because I really do think this model, along with telehealth, especially when you think about like the issues of digital health inequity in a lot of our communities, where they can't access telehealth, they can't access Wi-Fi, they can't do any of that. Their phone numbers are changing constantly, so you can't follow up with them appropriately. Like, getting into the community is really the key.
Fantastic. Thank you for that. And thank you all speakers. You've all done a fantastic job. And thanks to everybody for participating. So on behalf of Patrick Sullivan and myself, we want to thank everybody for being here today. And we'll see you August 5th for Dr. Patel. Thank you, everyone. Take care.